Uh, Good day, everyone. So today's topic is space maintenance. Space maintenance, as it is a very important topic, both for theory and practical as far as concerned, because whenever you are taking a case studies in practical aspect of pediatric dentistry, it is during examination, you will be coming across the tooth which has to be indicated for extraction. So whenever you're planning a treatment plan like extraction, you need to be specifically telling that whether there is a need of space maintenance and which space maintenance has to be given. So this is an important topic of for exam point of view. So space maintainer, coming to the definition, space maintenance, as it is defined as the provision of an appliance that is either active or passive, which is concerned only with the control of space loss without taking into consideration measures to supervise the development of dentition. And this definition was given by J.C. Breuer in the year 1941. Coming to the definition of space maintenance. So space maintenance are nothing but the appliances which is used for the space maintenance. So these are the appliances used to maintain space or regain minor amount of space lost so as to guide the uninterrupted tooth into a proper position in the dental arch. So why does regain minor amounts of space? Sometimes it is an active appliances and sometimes it might be a passive appliance. Passive is mainly meant for space maintenance. When it comes to an active appliances, it is mainly the active movement of tooth occurring. So there is a minor movement of tooth occurring there. In such cases, we can actually regain the minor spaces which has been lost earlier. So what are the objectives of space maintenance? Nothing but the preservation of primate space. Preservation primate space is an ultimate requisite. That is, primate space can be seen on both upper and lower arch. The position is different. That is in the case of upper, it is uh, distal to the canine, and that is to the mesial to the canine in the case of mandibular arch. So the preservation of normal occlusal plane, preservation of the integrity of the dental arches, because one premature loss of teeth can cause occlusal disparities. So it is mainly to preserve the integrity of dental arches. And in case of anterior space maintenance, mainly anterior space maintenance is ultimate for the aesthetic purpose and phonetics also. So what are the sequelae of early loss of primary teeth? Obviously, if a tooth is missing means there might be a supereruption. That is, if the tooth is lower tooth has been early loss, if there is an early loss of lower molars, surely there will be a supereruption of the upper molars. And when a tooth has been missing in the dental arches, the tooth which is there in the either sides of missing tooth can drift. That is, the mesial to the edentular space can drift distally, and distal to the edentular space can drift mesially. So there is a drifting of adjacent teeth occurring there, and loss of arch length, circumferences, and deflection of permanent teeth. If there is a space loss occurring there with the drifting of the space losses occurring and the drifting of tooth has been already occurred, there is sometimes a deflection of permanent tooth can be occur. Then is traumatic interferences and untoward jaw relationships finally. So the what are the ideal requisites of a space maintainer? The space maintainer should maintain the mesiodistal width of the tooth, the sufficient diameter, sufficient width which is there, um, which the tooth is lost means that space has to be maintained by using this space maintainer. So the ideal requisite should maintain the mesiodistal width of the tooth which has been lost. Simple and easy to fabricate and cost effective. It should not be too much of cost because this is just a temporary purpose. So it might be the lower limit. So it should be cost effective. Should restore function and prevent over eruption of opposing teeth. Should be strong enough to withstand the occlusive functional forces. It must permit maintenance of oral hygiene also. Sometimes it is very difficult to maintain oral hygiene if it is mainly a fixed phase maintenance. If the patient is already having some difficulty with the oral hygiene practices, if you are giving fixed space maintenance in such cases means they will be having a difficulty in retaining or in doing the oral hygiene practices. So, and main thing is it must not restrict to normal growth and that because we are giving this in a growing children. So, if the normal growth pattern should not be interfered. So, in such normally the growth pattern will be interfered by using a removable space maintainers. So, in such cases, we need to refabricate it every 3 or 4 months. Now, coming to the indications. So, mainly the indications of the space maintainer is to prevent the drifting, as the sequel explained, drifting, chipping of teeth, and to maintain the space. And it should prevent the loss of arch length, to prevent midline shift because of unilateral loss of deciduous teeth. Mainly, you can see the unilateral drifting of canine loss can lead to midline shift, and rest of functions, aesthetics, rest of functions is mainly with the use of a functional space maintenance, not with the use of other space maintenance like fixed non-functional. We cannot restore the function, but still it is has to be indication for space maintenance. Aesthetics, psychological reasons to prevent the ectopic eruptions. Now, coming to the contraindication. If the mesodistal width of the underlying permanent tooth is less than the space present, that is whenever we are going for a space maintainer appliances, we will be taking a radiograph prior to the space maintainer delivery. In such cases, if you are finding that the tooth which is underlying, that is permanent successor, is mesodistal width is more when compared to the space available. That is, space available is less means we cannot give a space maintainer because minor tooth movement only can be gained by using the space maintainer. In such cases, we can go for space regainers. So when tooth is near to the crest of ridge, usually the tooth will be erupting after the completion of the two-third completion of the two-third root completion. That is usually the last 2 stages of 8. So in such cases, if you are giving the space maintainer when the tooth has been reached the crest of ridge, means it's actually useless of giving them. So there is no use in giving such in space maintenance in such patients. And so in such cases, we can avoid giving space maintenance when the underlying permanent tooth is missing. If the underlying permanent tooth is missing, means there is no chance of but in such cases we have to consult with the other departments if they are planning for any implants and all, means we need to maintain the space when the molars are expected to drift forward. So this is the last 2 stages. It is 11 stages, which consist of 0 to 10, and from absence of rift to the apical foramen completely closed. In the stage A, that is two-thirds of root completion, usually the tooth will be erupting. The last 2 stages is an important criteria or ideal requisites before going for a space maintainer. Now the classification of space maintainer. Classification has been given by several authors. Coming to that, Hitchcock in 1973 has given removable, fixed or semi-fixed, with bands, without bands, functional, non-functional, active, passive, unilateral or bilateral. Raymond C. Throw in 1978 has given like removable, complete arch, that is lingual arch, extraoral anchorage, and individual tooth. Next is Henrichon in 1962. Fixed space maintainers and class 2 fixed space maintainers and removable space maintainer. Fixed itself, he has classified into class 1 and class 2. Class 2 is cantilever type and class 1 is non-functional and functional type. Non-functional is bar type and loop type. Functional is pontic and lingual arch type. Class 2 is, as I told, it's cantilever type. Removable space maintainer is acrylic partial dentures. So what all things have to be planned when you're giving a space maintainer? Time elapsed since tooth loss. How much time it has been taken? Because maximum space loss will be occurring after 6 months of tooth extraction. So the time elapsed since tooth loss is an important criteria. Dental age of the patient, because chronological age and dental age can be differ. So dental age of the patient is an important criteria. Amount of bone covering the unerupted tooth. It is actually 4 to 5 months. It may take around it might take around a 4 to 5 months to penetrate 1 mm of bone. So its amount of bone covering has to be taken in count. And sequence of eruption of teeth, and delayed eruption of permanent tooth, congenital absence of permanent tooth, presentations of problem to parents. That is the main thing. Coming to the removable space maintainers. These are the removable space maintainer. Fixtures, one fixtures, band and lip space maintainer. So I'll be talking about the distal shoes. So distal shoe is a space maintainer. Other name of distal shoe is intra-alveolar appliances or eruption guidance appliance. Mainly the to retain and guide the permanent first molar into normal. That's why the name like eruption guidance appliance, because it is actually guiding the eruption of permanent first molar. So the distal shoe is indicated in such cases that there is a premature loss of second primary molar as prior to the eruption of permanent first molar. So indications are maintained space of primary second molar that has been lost before the eruption of permanent first molar. If the two contraindication are if the several teeth are missing, because only we can actually plan a long distal shoe, but still it's actually technique sensitive, and it's very actually it is very difficult to do in a uncooperative kids. Poor oral hygiene, obviously, and poor certain medical conditions like blood dyscrasiasis, hemophilia conditions, we cannot give this distal shoe, and congenitally missing permanent first molar. So this is a pictorial depiction of permanent distal shoe space maintainer. Next is contraindication, saying what I told. So fabrication, it's the position and width of the distal extension is mainly depends upon the angulation of the sixes. There is eruption of sixes is the main ideal requisite in fabricating the uh, distal loop of the or a bar or loop type will be there. In such cases, it is very important to know the eruption pattern of the permanent first molar. So we'll be having a the length of the distal extension, horizontal bar measuring the second primary molar if it is not removed before. If we are planning the extraction and the fabrication on the same day means we can actually measure the second primary molar, the mesodistal width can be measured it, and the distance can be same resistance can be retained in the appliance also. And next way of assessing us horizontal bar length assessment is by mainly by taking the radiographs. The um, so the depth of the extension. It should be 1 mm below the mesial marginal ridge of the unerupted permanent first molar, according to Higgs. It is basically a V-shaped, should be sharp if inserted into extraction site after healing. This is actually a single day procedure. Can be polished and smooth if inserted on day of extraction. If it is too long, means it can actually cause injury to the second premolar. Because it is too long means it is actually hitting on the premolar. So it can pose a developing tooth can be harmed. Next is if it is too short means might the permanent first molar slip under the extension end. Thus, in such cases, the permanent first molar can go slip and then erupt into a different site. So this is a picture of a distal shoe which was given on a 4-year-old kid. Next is Nance holding arch, that is Nance parietal arch. So in Nance, it has been given only on upper, that is maxillary arch. That is, if it is it's a bilateral, fixed, passive, non-functional space maintainer. Mainly the button, there will be an acrylic button. It will be resting on the rug area. It's a small U-shaped pen. It is given which approximate 1 centimeter distal to the lingual surface of the incisors. Pen enhances the retention of acrylic button. Indications is mainly the bilateral loss of multiple primary teeth also serves as a because this Nance parietal arch can also serves as a habit breaking appliance. So in the same appliance, you can actually give a this tongue for tongue thrusting. We can give a fabricate tongue crib along with this Nance parietal arch. Disadvantage, if there is soft tissue irritation means we cannot give this because the acrylic button will be resting on the rug area. So this is a video representing the Nance parietal arch. See, there is a bilateral loss of primary first molars, and the band was fabricated. Both the primary first and second molars, primary second, first and second molars were missing in such cases. So this is without giving a space maiden, and this is a with a space maiden. So see the difference between the eruption, because one such case you can see. There is a canine over here and the primary D and E is missing. So we'll be banding, that is bilateral missing cases. In such cases, we will be banding the molars, that is for permanent first molars, and the banding, and additionally the retention is taken from the root area. The rectal button is resting on the root area. So that the mesialization, mesial movement or mesial drifting of the permanent first molar can be somewhat prevented. Next is transpalatal arch. Transpalatal arch is also a bilateral fixed passive non-functional space maintainer. It is actually indicated in if there is a unilateral loss of second primary molar after the eruption of permanent first molar. Second primary molar has been prematurely lost after the eruption of permanent first molar. In such cases, we can give the transpalatal arch. It is effective in preventing the molars from rotating around the palatal roots. It prevents anchorage loss. Transpalatal arch runs across the palatal wall, avoiding contact with the soft tissues. Next is fixed lingual arch. Lingual arch is bilateral only, but it is only indicated in the case of a mandibular arch. Bilateral space maintainer, but is most effective in the case of mandibular arch. And lingual arch, we can actually plan for lingual arch as an active appearance, because by giving a modification, we can actually upright the permanent first molars if it has been inclined or mesily inclined. If there is a mesily inclined permanent first molar, in order to make it upright, you can use the lingual arch. Classical mandibular arch wire consists of two bands cemented to the first permanent molars, or sometimes second residus molars, which are joined by a stainless steel wire butting against the four incisors. So make sure that in order to give the lingual arch, the lateral incisors have to be erupted, and the loop has to be resting on the wire component will be resting on the cingulum area, because the most stress bearing area. If it is on the tooth surface, means there will be a retrocline or proclination or mainly proclination of lower incisors will be occurring. So the stress bearing area, cingulum has to be considered for the resting. So this is a picture of a lingual holding arch, and this is a video of lingual holding arch, where the premature loss of primary second molar was there. That is 8485 has been gone, and see the 84 has been lost, and this has been erupted. 44 has been erupted. In such cases, we can give a lingual arch over here, and then bilaterally, we can place a permanent bands on the sixes, and additionally, the support can be taken from the anteriors. Now, coming to the modification, along with the hot lingual arch, we can give, that is hot lingual arch. That is, along with the lingual arch, we can give a U loop, so that activation can be done here. So that if the permanent first molar is easily inclined, in order to make it upright, we can use this lingual arch with canine stoppers. If the tooth movement is occurring, stop, because we don't want a canine to move easily. So in such cases, the distally. So in such cases, we can plan stoppers in order to prevent the distal migration of the canine. Omega bends can be done in canine region to prevent the interferences, which was suggested by Constantinus et al. So these are the pictorial depiction of a lingual arch, that is same for canine stoppers. These are the canine stoppers. Lingual arch with canine stoppers will be giving. And this was modified for erupting incisors. And this was Chawla modification. Next is Gropper's appearance. Gropper's is actually indicated for if there's a premature loss of upper anteriors. In order to prevent the patient from having any other occurrence of habits or other, if the patient is concerned more aesthetically, and in order to prevent in order to regain the phonetics, we can use this Gropper's. So thank you.